He received his medical degree with honors from the University of Washington School of Medicine and completed a family medicine residency for the University of Washington Spokane. He began his medical career in 1991 as a partner in family medicine in Port Angeles, and he enjoyed the practice of full-spectrum family medicine and high-risk obstetrics for 30 years. He was appointed as clinical instructor for the University of Washington Department of Family Medicine in 2010 and was twice elected chief of staff at Olympic Medical Center. In 2015, as FMPA senior partner, he led the transformation of the private practice into a federally qualified community health center, recognizing this model as the most effective and sustainable way to meet the growing healthcare needs of the community. He has served as Chief Executive Officer for North Olympic Healthcare Network since its inception, sunsetting his clinical practice in 2021. He is passionate about quality improvement, patient-centered care delivery, and health equity. He currently serves as board president of the Regional Olympic Community of Health, the executive committee for the Washington Association for Community Health, and is a member of the board of trustees of Maxwell College. In his spare time, here, you'll find him hiking, traveling, or behind a guitar.
Oh, very cool.
And please welcome Dr. Maxwell.
I'm actually having a little bit of deja vu. I was actually here in November in this room talking about some similar stuff and see some familiar faces. I think Grant is on every group I've ever talked about. But for those of you who've heard some of this, and my apologies if there's some redundancy, but hopefully there's something of interest. I'm primarily here to talk about our new health center site, new services, but I always like to kind of give a little bit of background for people who are doing this about us. So, there we go.
Let me go ahead and share this real quick. Slideshow. Begin. Oh.
That's Don also. So, there we go. Yeah, some update on our site services and our plans to come. So I would like to start with our mission, and that is to provide patient-centered, quality-driven, whole-person healthcare services that are accessible to everyone in the community. And this means a lot to us. This instills what we're all about, why we did what we did. I want to give you a real quick background on our history, our background, and what a health center is. So we are a 501c3 not-for-profit community health center. And we were established in 2015 after, as Lauren was mentioning, after we transitioned our private practice down in Port Angeles into this model, CHC model. And the reason we did that is that we just had to recognize that the model which had worked so well in the community and many communities for so long is really no longer effective. Private practice model will attract newer physicians to a rural community with primary care and have to actually invest in a practice and run that practice. There's just a shrinking supply of doctors. So we knew that this model was working well for us. It was not allowing us to get more doctors in the community. That was not true. So we had to make a change. And so what we did back in 2015 is we applied for the opportunity to become a community health center. It's an option that comes up periodically through the Health Resources Service Administration or HRSA. These are competitive grant opportunities that are established to put health centers into medically underserved communities. The competitive grants and those opportunities came about in 2015, and we applied. There were about 2,000 applicants and 164 grants. We were one of the 100 in the nation that selected. Which was very, very fortunate to actually get this. And we became at that point a North Healthcare Network. And the reason we did this was to solve the problem that we've been struggling with this for so long. I'm not sure if those of you were in town in 2014, remember, if you didn't have a doctor, you were not going to get a doctor. It did not matter what your insurance was, it just were not enough primary care providers for that. And so that was the driver for why we made this change. And our goal for doing this was to try and solve that problem and improve access to the community. So what exactly is a community health? You'll hear the term FQHC, or Federally Qualified Health Center, or Community Health Center. You hear those terms, they mean the same thing. They're synonymous. FQHC is just a term that's used for a reimbursement model, but they refer to the same entities. In a nutshell, FQHC are nonprofit, community-based, and patient-directed organizations. I'll get to that a little bit in a minute. That serve populations that have limited access. That's what a community health center is in a nutshell. The health center program was established actually back in 1964 as part of the Civil Rights Act. It was there to address disparities in healthcare access that were particularly prevalent in inner city, urban, and rural America. Most often, their population of color that didn't really matter. And this program was designed to get healthcare resources in those underserved areas. It started out as 2 health centers, one in inner city Boston, the other one in rural Mississippi. And it was back in 1964. And since then, it's been expanded under every administration's and bipartisan support for the past 50+ years. There are now 1,400 health centers nationwide. Washington State has 27. We are one of those 27, and we are the newest one in Washington State, one of the newest in the nation. Collectively, health centers serve about 31 million people. 8 million of those are kids, and over 4 million will be veterans. Collectively, the health center program is the largest health system in the country. So there are the health center program is very complicated. There are some 6 basic fundamentals that distinguish us, that describe what the health center program is all about. As I alluded to, a key feature is they must serve areas that are medically underserved. So this was HIPSA means health professional storage area or medically underserved area or population. These are federal designations that recognize that in a particular area, population is not getting access to that, does not have enough health providers around. Port Angeles has been a HIPSA designated area for the past 25 years. So we are recognized as federal government as someplace who does not have traditionally enough access to health care. So it was that designation which allowed us to apply for this health center designation. A key component of the health center philosophy program is health centers are patient-directed. That means that they're responsive to the needs of the patients as patients find that. So one of our key fundamental requirements is that we are governed by a board of patients. We have 11 board members, and 9 of our patients are person requires at least 51% of patients. Now, they don't actually run the health center, but what they do is they represent the patient, they represent the community, and say, what does the community need, what do the patients need? Are we providing services that are responsive to what those patients need? So it's a key component. Health centers have to provide a comprehensive set of health care services. Primary care, dental, behavioral health. We now do optometry, and I'm going to talk about that more in a minute. Provide nurse care management, enabling services, so we provide transportation, translation services, care coordination, navigation, outreach, like social work that deal with non-medical barriers of care. The idea is that the health center program was the very first, all the way back in the 1960s, had this idea that the best health care was when it was comprehensive and integrated in one health system. Now we say, well, no doubt. And that's what everyone says now. But this was the health system program was the very first to have this idea. It's kind of radical back then. It's proven to be the most cost-effective and the most clinically effective way of delivering care. This another key component is that nobody is turned away. Not as insurance. Whether or not, nobody's turned away. So if you ever hear anyone say, "I can't afford to get health care," that's not true. At least primary care services. Health centers will see anybody regardless of their ability to pay. They're charged to be used based on their sliding fee scale on their household size. So we make sure that all healthcare services are affordable. When we do so, that we qualify all the way down to no charge at all. That's a key component of the health center program. Another is that by nature, health centers are collaborative beasts. Unlike a private practice, which focus inward on taking care of business inside the house, health centers are outwardly directed. We're connecting and collaborating with other healthcare organizations, community organizations, try to identify needs and try and address those needs collaboratively. North Olympic has a great relationship with OMC, OMP, Jamestown, PBH, the health department. We have projects going on all the time with them. To work collectively to try to address it. And that comes at a cost. I mean, there's a high level because we have some federal funding. There's a lot of accountability. We have to provide data to the federal government on our cost, utilization, staffing, outcomes on a regular basis. And we do this, and we're subject to the federal side business every 3 years. We have to prove every 3 years that we are assessing the patient's community's needs and effectively addressing. The reason this is a key part of it is that the health center program first goes to Congress every year to get appropriations to support all these focus on health care. And they want data to say that we're having an impact, we're actually making a difference. And the data is compelling when we get to that we are. I want to talk a little bit about this, about the impact for us locally. Remember, the whole reason we did this as a clinic as well as we thought it would help through healthcare. And it's been successful. But since doing this, we've brought 15 new positions in since 2016 and 10 new practitioners. There's a variety of reasons for that. One is that working at a community health center qualifies for national health service for loan repayment programs, so that those coming out with high educational debt. If you go to nursing school, you'll have that. That when you come to work at a health center, you can have that debt forgiven. So that can be an incentive for bringing people into the community. The other is that the model is very attractive. Physicians, particularly new physicians, really appreciate and value this idea of working with a team, with a bunch of other technical providers, being able to work in an integrated fashion, and having a health center model is a great place to work. Another is that we have established, I'll leave this in a bit, a residency program. So we actually have a residency associated with the health center, and many of these physicians. So all of these things cumulatively help to attract providers in the community. With that extra 25 providers, we've been able to take on 11,500 new patients since 2016. These are people who are previously knocked on doors and turned away. But as we've been successful in getting more workforce in, we can take care of more people. We take on about another 150 to 200 patients a month, and the lead is still there. We've gone from 5,000 patients up to 2,000 active patients. Those are those who consider North Olympic as their home. We had 57,000 visits in 2022. About a third of our patients are Medicaid patients. About 35% of Medicare. We talked about demographics. Another 30% are commercial or major uninsured. Those uninsured, we are safety net 9%. We have their fees reduced all the way down to zero, depending on the house size income. We've been able to establish with this on this model an increase in behavioral health staff for the community. So there's a lot of behavioral health issues in the community. For instance, has been at a high level of substance use, overdoses, depression, anxiety, suicide. We've been very higher than state averages for all those, which is reflective of a high prevalence of behavioral health issues in the community. So we've wanted to beef up our capacity to address those needs, and we've been established the health department, and actually have psychiatrists staff. There's a lot of different values in this. We established a new dental clinic in 2019. This is the first new dental access for patients with Medicaid in over a decade. So Medicaid typically reimburses poorly, and so very often practices limit the amount of Medicaid they can see, so it makes it difficult for patients with Medicaid to get access to services like dental care. They're all ending up in the ER with advanced tooth decay, abscesses, pain, and until we got this going, that was the only place we get dental care. It's not we want to do dental care. But since this, we've done this, we've seen thousands of new patients every year. Even how we I talked to Daryl at the hospital and said we've seen their dental visits in the ER just drop off the home. And as I mentioned, we started a residency program to help train new physicians. There's a lot of evidence that when you train a physician in the community, they're more likely to stay in that community long term. This is the goal of trying to help with long-term workforce pipeline. I mentioned collaboration agreement. I'm just going to run through a few that we're engaged with right now. There's something called the Accountable Communities of Health. They're statewide regional collections of regions that where different kinds of health providers and community-based organizations collaborate. It's called Regional Health Collaborative to try and address complex health issues that no single sector can attack alone. So this is Colin Jefferson and Kitsap all together in what's called the Living Community of Health, and we meet every month to work together to look for projects on ways that we can streamline and address some complicated health issues that no single agency can tackle by itself. I'm the president of that board this year. It really has a lot of impact. And we're a key part of that. I'm in here, so we have a collaboration with the school district. We've provided health services to the school district since 2017 or 18. We started in a closet in the high school and found out that wasn't really cutting it. And so we discovered that the needs were far beyond high school. And so we instead of trying to bring all the students across the district to the high school, we decided we're going to start a clinic on wheels and go to each of the schools in the district, middle, elementary, and high schools. And we finally got this. It's kind of hard to miss it because it's a billboard on wheels. And if you see it, we're probably on our way to or from one of the schools to provide primary care, but really a lot of behavioral health services to the district students. And just so for parents in the room know, if you guys get a sore throat or get sick or just don't feel good, you don't have to kick off the school and travel to town. You can actually check to see if the mobile was there and you get evaluated. We have a collaboration with the Florida Fire Department called Community Care Medicine. This is a program to try and get high risk, high utilizing vulnerable people who typically end up frequently decompensated in the ER repeatedly. And this is the idea is that we reach out to them proactively to keep tabs on them. We go to them before they need help to keep them out of the ER. And this is something that Ken Dubuque, the former fire chief, had this idea. He came to us to see if we would support it. And we thought it was a great idea. So our providers and our community health workers worked with them on the program. We actually were able to find some private funding to help expand this from one community paramedic to 3, and that's tripled the impact itself. Our clinic was a big part of the collaboration with the health department on mass vaccination clinics. I'm not sure how many of you went through those at high school to get the COVID vaccine, but it was the quickest way to try and get the vaccine out to the most people who need it as quickly as possible. And that was a very impactful. I think we gave out 18,000 to 20,000 vaccines from that. Again, another collaboration, our residency is a collaboration between us and Sweden, Seattle and OMC. So we have the residency, a 3-year residency. They'll do their first year at Swedish in Seattle, and they'll come out to Los Angeles. It's then kind of our clinic the next 2 years to do their ambulatory care training, and our physicians work with them at the hospital on their inpatient. So just a little bit about responding to needs. Again, that's what we're all about. It's identifying needs and responding to that. One of the key components of that is something called a community health needs assessment. The hospital does this, the health department does this, but we also do a needs assessment on a regular basis. We try and so some of you may get surveys.
No, that's perfect. Thank you.
And what does the community perceive as its greatest health needs? The last time this was done, there was no surprise that there's still a huge need for primary care. Despite those 11,300 patients that we've taken on in the past 6 years, there's still a lot of people waiting to find a doctor. When we were doing those mass vaccinations, we do, we ask everyone, so where do you get your primary care? And it's surprising, shocking how many said, I don't have one. I don't have one yet. I just moved to town. I don't have one. Or I've been here. I don't think I need it. They're going to need it at some point. So there's still, we know there's a lot of demand for primary care yet. There's still need for more. And we all know that there are physicians in the community who've been here for a long time when they're retiring. When they retire, there is nobody else waiting to buy their practice to take over the patients. That ship has sailed. So we're trying to prepare for what do we do when they retire, when patients needing their primary care conditions. We've had a wait list that's been growing. We've been trying to work it down. As we talked about earlier, there are some challenges. Despite successes with recruiting, it is hard still to recruit primary care providers to the local community. There's the healthcare workforce took a hit during the pandemic. It's a stressful job, and across the country, a lot of people left the healthcare workforce, and trying to find new positions want to come out. It's still difficult. So we're working hard, constantly trying to recruit and having some successes, but we need more. And we need to create the space to accommodate that. So that's why we decided to get out in front of the curve and create new space capacity for these extra positions that we formed in the. So we back in this last month we opened a new service site. 1026 East First Street. Everyone knows this building from down Port Angeles. We call it Eastside Health Center because we're not going to imagine it. This is going to allow additional primary care and more capacity for behavioral health providers. We did build in some capacity to be able to do telehealth because that is something that we learned during the pandemic there was a demand for. We still are figuring it out and the best way to deliver that, but we think it will help people, especially younger generations who are looking for healthcare, not necessarily face to face, but they like it on the phone. So we'll figure out how to do that. As I mentioned, we are doing a new service. We just added optometry or vision services that are going to be available to particularly the Medicaid population, which are otherwise having hard time getting access to services. We project adding 20 to 25 living wage jobs, which will put us up over 170 employees and fully staff. That's compared to 35 back in 2015. So I had jet black hair back in 2015. The project, this adds a great hairs. It's a $5 million project that we essentially doubled in cost when we first started it, thanks to the pandemic and supply chain issues and all that. So it was a $5 million project that was financed through a combination of some low interest loans that we were able to partner with HRSA on, some limited capital grants, and then some reserves. I do want to acknowledge that the Foundation did give the $25,000 grant to help purchase some of the equipment for the vision department. it is really expensive stuff. It's crazy how expensive that vision program is. So this is for the old timers in the room. This is before my time. Some of you guys may tell me something about this. I was trying to, this building was built in 1940. I actually learned that it started out as computer sound transfer and storage. I believe I was told it was built, I learned, by the uncles, great uncles of one of our first board members. That's in the era. That's the only thing we can find from the historical society. The oldest buildings we have that we have of what that building is like now. I guess it's a grocery store. Is that right?
Right.
Well, yeah. So it's not a big parking lot, but I was trying to figure out based on the prices about exactly how old this is. It's pretty cheap prices anyway. 50s, right? Yeah, before my time. Barely. Then, there was a lot of stuff. There's real estate offices. I've heard all kinds of stories. I'm trying to talk to somebody. I found out something else building at one point. So this was back in 2013. It was Apple Healthcare. Then it was the Atticus with the famed pizza oven, which is no longer there. I'm sorry to inform you. We tried to keep the pizza oven, but we couldn't work it in there. And then it was Edna's place, and this is when we bought it from Edna. It looked pretty much like that when we purchased it, and that's what it looks like now. So not a lot of difference on the exterior. A little bit mostly it's change in sight. The interior, however, is a different story. The lot is different. So this is when we purchased it. This is what the upstairs looked like. So for those of you who are involved in nonprofits now will recognize this because Edna, out of the goodness of her heart, was providing storage for all the nonprofits for all their equipment and stuff. Festival Trees kept their stuff up there. This was it was a rat warren. It was just all kinds of nooks and crannies everywhere. When we did the demolition, this is what it looked like during demolition. So there's a lot of space up there. That's about 4,000 square feet upstairs. Well, people don't even know there is that. And this is what it looks like now. So it was quite a bit of transformation. It was really good space. We were able to keep those floors. Those are from the 1940s, and seen a lot of life, a lot of traction. They vacuumed out 250 pounds of dust and glitter out from beneath the floorboards. So on this is the same second floor, you're looking the other direction, and this is I think we've got the material put there. It accommodates about 20 staff. That's quite a bit of space. If you were to go in the front doors at demolition, this is what you would have seen. Pizza oven was about right there, and this is what it looks like now. So, it's quite a bit different. The old Edna's place had this open meeting area, and this one was in demolition, and that's what the cooling area was like now. In the primary care area, this is lots of trenching to put in plumbing that wasn't necessary for Edna's place. So it was a project. We'll put it that way. Renovation of almost 80-year-old buildings, full of surprises. And this is what it looks like now. So this is yearly construction. It was a general contractor using a lot of local subs. They just did great work. We did food bank, Williams Shore Pool. We did just that. This is back at the kitchen. You see an old walk-in refrigerator right there, but this is looking through the kitchen area, the old Atticus, and this is what it looked like after all the walls came down. And you'll notice that there's a post every 16 feet throughout the entire building. So at the stage. So we had to design the clinic around those posts. And our architect did a good job about figuring a way to fit everything in there. And this is what that space looks like now. This is where the providers would do their work. Looking down where the vision area is right now, that was before, and this is after. This the hallway leads from the vision area, and then this is what the UI care center is. Separate entrance, and it's some patient staff. So that new service, optometry, it's new for us. We want to make sure we guarantee access to the optometric services for our patients with Medicaid. Otherwise, we have difficulty finding it. Dr. John Heward, who many of you might know, has been in practice since 1995. He's a great optometrist. He was actually my optometrist for about 4 years. And he was one of the few optometric providers that are seeing a high volume of Medicaid. He would, I think his practice medicine, it's harder and harder and harder to do the business of it and take that vision. John was finding this was taking more and more of his time and taking him away from primary care for the patient. So during one of my eye exams, one time I said, well, would you consider another alternative? And those discussions evolved over time where he said yes. So he wanted the opportunity to be able to focus on taking care of patients, he had to have it. So he joined Known in 2023 and began seeing patients February 1st. Our new Eastside Health Center accommodates 2 lanes, provide a full range of vision services. We are not dispensing hardware at this time. It's a whole other thing. It's a talk in itself about the economic and the incentives for doing hardware. We are not at this time, because there's a lot of barriers to that, and we may over time. We have everybody's praise for children that are Medicaid. The services are available to all known patients, including those who are uninsured. Now, one of the things you might hear about is, for those of you who were seeing Dr. Heward before and now heard that you can't, that you're a known patient, the reason for that is because one of the first requirements for us as a health center is that we can only provide services to patients who are patients of the health. So it's not any reason to be compliant. If you like, we will have the patient that work with it, and you can see that here. So what's on the horizon for us? Yeah, okay, good. So our real focus now we've done this, is to fully staff now at this new health center. We've created space for 5 new primary care providers. We're actively recruiting to try and fill those so we can position ourselves to take care of the wave of demand that we see on the horizon. We're going to try to optimize optometry. This is a new service for us. It's new to us. I'm just a student doctor. I don't know about optometry. So I'm still learning how to do this and do this right. And luckily, Dr. Heward's got lots of experience and is going to get us off the late start. We are looking at potentially bringing services to the West End. I think you can see their CEO. We won't go unless there's actually need, but there's some struggles out there, or there are some need for services, primary care, dental, behavioral health. We can get much of the workforce to do it. We can try and bring some of the services out there at the West End. We're looking to grow our behavioral health capacity. I think there's still growing need there. Expand our telehealth services and really focus on graduating more residents from our program, which has expanded from 2 residents per year to 3 residents per year. Just last year's class, or the class before, 2 residents, both residents stayed in the community. So it's a sign that does pay off. Roughly about 50% of the residents eventually do stay. Not all do. This year's class, they both want to stay, but they have obligations to other states as part of their loan repayment. But when they pay those off in 2 or 3 years, they express interest on returning plan. We're going to grow our community health worker outreach resources. These are our people who work for us, but we go out into patients' homes. These are high-risk patients to help them work through various repair. And as I alluded to, that community health needs assessment, which is something we do periodically, we're going to be doing that this coming year. We make sure we have a good sense of what community needs, patients need, and we'll do our best to respond to those needs. And we're going to continue to work collaboratively and expand our care transformation activities. So that's all I've got. Any questions related to 2 minutes?
Dr. Maxwell, I'd just like to publicly thank you for all the services you brought to the community. And the older I get, the more I really appreciate it.
Thank you, right? Yeah. The worst part about this, of course, my career took a different direction than I was planning. No one aspires to be an administrator. But it's something I just sort of current took me, but I miss seeing patients and this.
We miss you too.
So it's good to see you like this.
Thank you.
Yeah.
If you were not limited with the numbers of available healthcare workers, how many would you try to hire in the next year?
Oh, geez. We hired 5
Physicians,
positions.
and then how about the associated nurses?
I would say probably collectively 5 primary care providers. So we kind of use them saying we sort of have, because physicians are hard to get a hold of, we sort of were targeting 2 or 3 physicians and 2 or 3 APCs, advanced practice clinicians.
Thank you.
Yeah. But we will be hiring nurses later.
Yeah.
Yeah, in addition to, it's challenging, you guys, but it's like this issue for a lot of professional services. I know COVID mentioned,
Great question. You're spot on. This pandemic really put a wrench into a probably tenuous ecosystem, and we've been working very hard on on wellness. We've been trying to reduce the schedules to a point, because that's stressful. When you do that, you reduce access to patients with the balancing act. We've done lots of just group activities and focus on wellness and a little bit of impact. We really do a lot of listening to understand what are your pain points and what we have to do to try and modify things to make it better and increase the acid fraction. And then a lot of the economics have been turned upside down, and so we've had to do a lot of justice in compensation. That's what the market says, but it's been stress. So, well,
I wanted to maybe ask you in terms of future updates, if there's anything I'm sure you could interact with your team or stuff that I'm wondering what sort of expectations you have for population.
it's a great question. I've seen all kinds of projections that I can see the range of projections about what that one is going to be, and instead of fine tuning that, we're just saying we just need more. That's simple. Yeah.
So we're hearing from some of the other really large employers that housing is a real problem. Is it affecting you too in your recruiting?
Absolutely. In fact, I lost 3 medical assistants a year and a half ago because their landlords converted their house rentals into Airbnbs, and they could not find any place else. So they left the community. And as we are looking at new providers, we are upfront saying housing is hard to find and expensive, but fortunately we've been able to kind of just have the right thing come up at the right time. But it's a worry for sure. Not as great a worry for our higher wage provider staff, for our support staff. It is people who know the economics are just not good. We try to provide living wage jobs when the cost of living is so high. There's only so high we can, push wages to compensate before we go under. It's a real challenge. Katie?
Well, I'm just curious, if there's an impact on.
That's one that, let's just talk more earlier, it's, they talk about housing, local school. Actually, most young providers are of childbearing and or have kids. And that has, I've only recall one that had enough concern about perceived lack of support in the community for the schools that they chose somewhere else. But but it does give some pause, yeah. So it's making sure that we have the best interest of the as an organization, most important, make sure that we are demonstrating our support for the schools. Will help all of us get help.
We have time for one last question. Well, Dr. Maxwell, I want to echo what Roy's saying earlier. It's a huge honor to have you in our community. We want to thank you.
Thank you very much.